Welcome. Hi, I'm Steve Elias. I'm the director of the Center for Vein Disease at Englewood Hospital in Englewood, New Jersey. And we're here at the VEITHsymposium 2019. And I'm here with Ellen Dillavou, who is the Associate Professor of Vascular Surgery at Duke University. And we're going to be talking about, amongst other things, perforators and where perforator treatment fits in, how you make the diagnosis, and who should get it, who shouldn't get it, more importantly. Also, I'd like to tell you, aside from Ellen being at Duke University and being Associate Professor of Vascular Surgery, she's also a very good friend, and we've worked together a lot on venous problems and at many meetings. So Ellen, the question is, we've had problems in the past with too many people treating too many perforators. Do you think now has the pendulum swung, and do we now have people, not enough people, treating not enough perforators in the right patient?
I don't think so. I think that the indications for perforator treatment are very defined. I adhere very tightly to the American Venous Forum and Society of Vascular Surgery guidelines. So that means that your perforator needs to be at least 3.5 millimeters, refluxing at least a half a second, and in the vicinity of skin damage, an ulcer, or a healed ulcer. And honestly, you and I both know that most venous practitioners aren't treating that population. Most people are treating patients with less severe disease or cosmetic disease. And I don't really think that perforator ablation has a place in that practice.
No, I agree with you. With the early disease, absolutely not. Where I was going with the question is, are not enough people treating not enough patients, meaning that in wound centers and people who are taking care of the wounds, they are not aware of even looking for perforators, and they don't even consider sending the patient to a vascular surgeon or a interventionalist who does treat perforated disease or advanced disease. Do you think that's been an issue?
I completely agree with you, 100%. It's really amazing to me that so many wound care centers don't have a direct venous referral pattern, because along with perforator disease, there's a lot of venous disease that's not being treated at all. And we could better these patients and get the wounds healed a lot faster if we were more aggressive with venous treatment. Every wound care center should either be able to be doing reflux exams and looking for perforators, or have a reliable way of getting them to a venous professional so that this is done.
Right. And to me, that's been the issue. I mean, I recently said, I really think that C6 disease in 2019 is the new C2 disease. I think that we now have many more technologies to treat advanced disease, between perforator ablation, stent placement for obstructive disease, even angioplasty for infrainguinal deep disease, as well as the usual endovenous ablation and stuff. I think our biggest bang for our buck in terms of helping patients is really going to be focused on the advanced disease like C6, and it's up to us to make people aware of this. What do you guys, how's your algorithm or the working relationship at Duke regarding getting patients with advanced disease to be treated appropriately with either your surrounding wound centers, or is there a wound center at Duke itself?
There is a wound center at Duke, and I still feel like this is a work in progress. We communicate with them regularly, and we get referrals, but we're not getting as many referrals as we should. You know that 40% of wounds in a wound care center are venous. And so those referrals should be coming in consistently, and they're not. We visit, we educate, we get some referrals, and then it sort of trickles down. So honestly, I'm still working on that. What have you done to create that referral stream where you are?
Well, we've actually, at Englewood, it is actually the Vein Center Wound Center. They are physically in the same place. And I think that's good for patients. It's also good for referrals. It's good for continuity of care. So where I think things should go is either the vascular surgeons spend time at the wound center, or physically they're in close proximity, because it's easier then to go across and say, hey, can you look at this patient, or does this patient need something done? That to me is the ideal. And for whatever reason, we're just lucky that we started this like 20 years ago doing it this way. But the problem is when they're even physically separated, that is an issue. Let's get to the issue though of data.
Yes.
Okay, so some people say, oh, treating perforators has nothing to do. It does not going to add anything to the healing of the wounds. Recently, there was a trial that was done.
The SECURE trial.
Yeah, so tell us a little bit about the SECURE trial and kind of who it identified to treat and what were some of the results.
So the SECURE trial was really one of the first well-done studies looking at endovenous ablation of perforators. And it was funded by AngioDynamics, and you use the AngioDynamics kit. And what they did was recruit patients, CF4B through 6, from around the nation. It was a multi-center trial. And then they looked at technical success as well as clinical success. The technical success was over 90%, and their closure rates were much higher than historic controls. And so, what this showed us is that this is a very reliable, reproducible way to close a perforator. And they had good ulcer healing and response, although the study wasn't powered with enough patients to make wound healing claims. What they saw was that people with wounds had the sizes and the number of open wounds decrease. So that's exactly what we want to see.
And I agree, and that's been my experience. And just for full disclosure to our listeners, I mean, I was part of the trial also. Most of us do feel ablating perforators in the right patient does add to it. So what do you consider the right patient? Not what is a pathologic perforator, but where do you see perforator ablation in the algorithm of treating venous ulcers? Is it first, last, somewhere in the middle? Where do we go? What's your algorithm if you have underlying venous pathology? Where do you put most of your money, second and third?
Well, if we get a new patient with an ulcer who's never been worked up before, we do a reflux study and looking at the saphenous veins. We do a perforator study, and we look at the groins to see if they've got common femoral reflux. We also now are going to a deep venous evaluation very soon. So I personally ablate the saphenous vein, look at the deep system, and then if they're not having rapid wound healing, then go after the perforator.
Yeah, and I think that's the point we should make to our listeners, is that perforators in general is not the first thing you go to. You kind of take care of all the other stuff first, right, whatever they have, and then if you're left with a non-healing wound with perforators, that's when you kind of go and deal with the perforators itself. And I mean, to me, our job is educating twofold: the wound centers to get the patients to us, and then the vascular technologists to look for the disease, and the vascular surgeons to treat the disease. And hopefully we can make some impact just in treating advanced patients with wound disease, with vein disease.
I think we already have. I think that talking about advanced venous disease goes on a lot more now compared to 5 or 10 years ago. And we've got better tools and more education about advanced disease. And so I think it's on an upswing.
All right, good. That's what I said. Well. C6 is the new C2 disease in 2019. So I want to thank you, Ellen. We'll shake your hands.
Pleasure.
And
thank you.
Thanks a lot.